So today we're going to talk about aortic stenosis. So that is, stenosis basically means narrowing. So aortic stenosis basically means narrowing of the aortic valve. So as you might know, this is the heart, the right atrium, right ventricle, left atrium and the left ventricle, and the aorta arises from the left ventricle and supplies blood to the body, and the aortic valve is the valve between the left ventricle and the aorta. So basically aortic stenosis is narrowing of this aortic valve. So what happens when this narrowing occurs? We'll see that over here. So the normal aortic valve area is about 2.5 to 3.5 centimeters square. That's the normal area, and due to narrowing, this area decreases. So the hemodynamic effect occurs when the valve area is less than 1 centimeter, and the symptoms start occurring when it is less than 0.7 centimeter square, and critical stenosis means when it is less than 0.5 centimeter square. Just for an info. So now moving on to the causes of aortic. So what causes this narrowing of the aortic valve? So basically we can classify the causes based on the age group which it occurs. So congenital stenosis usually is seen in infants, children and adolescents because the symptoms will be apparent from the birth or childhood itself. And the other causes may occur in young aged or young adults to middle aged, or in middle aged to elderly. So the congenital aortic stenosis usually occurs due to some developmental deformity, and maybe congenital aortic stenosis or subvalvular or supravalvular. That basically means above or below the valve. This stenosis may occur. Okay. So now in younger adults to middle-aged, that is, the symptoms tend to appear later. The most common causes are rheumatic heart disease. So due to rheumatic disease, heart disease, it affects the valves of the heart, and it may affect the aortic valve, leading to damaging of the aortic valve and aortic stenosis. Another cause is calcification or fibrosis of a congenitally bicuspid aortic valve. Okay, so the valves, normally the valves between the atrium and the ventricles are bicuspid valves. That is, they only have 2 leaflets in the valve, whereas the valves between the ventricles and the outflow, that is the right ventricle and the pulmonary artery and the left ventricle and the aorta, are tricuspid valves. That is, they have 3 leaflets or cusps, that is 1, 2 and 1 leaflet over here. So they usually have 3 leaflets or cusps. So when one of these leaflets is absent congenitally, it leads to a bicuspid aortic valve. So due to this, there may be calcification and fibrosis of this bicuspid aortic valve, and this may be a cause, and this usually occurs later in age. This calcification of fibrosis takes some time to develop, so these patients usually present as young to middle-aged. Even though they have a congenitally bicuspid valve, they're present in young to middle-aged. Okay, so in middle-aged to elderly, the causes are senile degenerative stenosis due to age-related degeneration, again calcification of the bicuspid valve, and rheumatic aortic stenosis. So those are the causes of aortic stenosis. So generally we have to remember, in infants and children it's congenital causes, in young adults to middle-aged rheumatic fever and calcification of bicuspid valve, and middle-aged to elderly it is senile degenerative stenosis, and again the same thing, calcification and rheumatic aortic stenosis. Okay, so now there's something called as valvular aortic stenosis. So valvular aortic stenosis basically means the aortic stenosis that occurs due to either this calcification or fibrosis of the valves. That is basically what you mean as valvular aortic stenosis. So congenitally bicuspid aortic valve. So there's something called as valvular aortic stenosis. So what is a valvular aortic stenosis? It basically means aortic stenosis occurring due to calcification and fibrosis of this congenitally bicuspid valve. So this is also called as valvular aortic stenosis. Alright. So that, now the etiology is over, we'll go on to the pathophysiology. So what happens when this aortic stenosis occurs? Okay, so now going on to the pathophysiology of aortic stenosis. So what's the basic problem here? The aortic valve has narrowed. There is narrowing of the aortic valve. And so because of this narrowing, there is a left ventricular outflow obstruction. The heart cannot pump blood into the aorta. But the requirements of the body remain same. So the heart has to somehow find a way to pump enough blood to meet the demands of the body. So initially it manages to maintain the cardiac output. How? By increasing the pressure. It starts pumping with greater pressure through this narrowed valve, and it tries to maintain the cardiac output. So initially it is maintained, but there is increasing pressure in the left ventricle. So there is a steadily increasing pressure gradient that develops across this aortic valve in order to maintain the cardiac output. So because of this increasing pressure, the left ventricle has to do more work. It has to pump harder, it has to pump faster in order to increase the pressure and get more blood through this narrowed valve. So what happens? There is left ventricular dilatation and hypertrophy. Because it has to do more work, the muscle starts getting bigger, and there's left ventricular dilatation and hypertrophy. The second thing that occurs. So normally this wouldn't be that much of a problem because, okay, let this left ventricular dilatation and hypertrophy. So now what? So now what is the problem here? The cardiac muscle has increased, so it requires more oxygen. It requires more blood supply. So normally this wouldn't be a problem. We just increase the blood supply to the cardiac musculature. But as you all know, the blood supply to the heart comes from the aorta. The blood supply to the heart itself also comes from the aorta. And here in aortic stenosis, due to the stenosis, we cannot increase the blood supply because the heart is already struggling to maintain the cardiac output through this valve, and it cannot increase the cardiac output beyond a certain limit because of the stenosis. So now, because of the hypertrophy and dilatation, the muscles require more blood, but the heart cannot supply more blood due to the stenosis. So what happens? There may be ischemia of the muscles. The muscles becoming starved of oxygen, and so angina can develop. So why does angina develop in aortic stenosis? Because there is increasing pressure gradient across the aortic valve in order to maintain the cardiac output. So because of the increasing pressure gradient, there is left ventricular dilatation and hypertrophy. So when there's more muscles, the muscles require more oxygen, but the heart cannot meet the demands of the cardiac muscle itself because it cannot increase the blood flow through the aortic valve. So the cardiac muscle doesn't get enough blood supply, and so it can lead to angina. Even if there is no CAD, it may lead to angina and ischemia of the myocardium. So as the disease progresses, now the heart muscle has increased. The heart is not getting enough blood to supply its own muscle, so it cannot pump as effectively as before. So steadily this cardiac output starts decreasing, and hence the blood supply to the body also starts decreasing. So there may be a low output state. So because of this, there may be fatigability, there may be syncope, exertional dyspnea, etc. So why does syncope and fatigability occur? Especially exertional symptoms develop in these patients because on exertion, the demands of the body increase. Just as we said before, when there's hypertrophy and dilatation, demands of the myocardium increased, and the heart could not meet it because of the aortic stenosis. And here during exertion, demands of the body increase. Again, the heart cannot meet it because it cannot increase the cardiac output due to the narrowed aortic valve. So again, there may be symptoms like exertional, syncope, fatigability, etc. Syncope occurs why? Because during exercise, there is more demand of blood by the muscles, and so but the heart cannot increase the blood supply, so the brain gets less blood, and it may lead to episodes of syncope. So eventually the left ventricle can no longer overcome this outflow obstruction. The demands of the body start increasing. The heart will not be able to maintain this high pressure state for long. So what happens? Left ventricular failure develops. Heart cannot pump enough blood adequate to meet the demands of the body, and finally it may lead to pulmonary edema, heart failure, and other complications. Okay, so now we'll go on to the clinical features. So the clinical features, we are divided into symptoms and signs. So the symptoms in mild or moderate stenosis, that is the valve area has not reduced that much, it's usually they remain asymptomatic for a long time until a significant stenosis has developed. Now, what are the three cardinal symptoms of aortic stenosis? They are exertional dyspnea, angina, and exertional syncope. So why does this occur? Exertional dyspnea occurs because of cardiac decompensation. Because there's when we do exercise, there's increased demand on the heart, and the heart cannot keep up with that increased demand because of the narrowed aortic stenosis. It cannot pump enough blood through the narrowed aortic valve to keep up with this increased demand. So that leads to exertional dyspnea. Now, why does angina occurs? As I said before, there's dilatation and hypertrophy of the cardiac muscle, but we cannot increase the blood supply to the heart because of the narrowed aortic valve. So the heart does not get enough blood supply, and that can lead to ischemia and angina. And why does exertional syncope occurs? Again, during exertion or exercise, there's increased demand on the body. The heart has to pump more blood to meet up with the demand because there's more demand from the muscles during exercise. But the heart cannot increase its demand because of the narrowed aortic valve during exercise. So what happens? The blood does not go to the brain properly, so there can be syncope. So these are the three cardinal symptoms of aortic stenosis: exertional dyspnea, angina, and exertional syncope. The other symptoms may be sudden death or episodes of acute pulmonary edema. As I've said, why? Due to LV failure, it can lead to acute pulmonary edema. Now the signs. In BP measurement, the pulse pressure may be decreased. Why? Because the systolic pressure is maintained by the pumping of the heart. That is, during systole, heart pumps blood through the left ventricle pumps blood through the aortic valve into the aorta, and that is what maintains the systolic pressure. Now the systolic pressure gets decreased because the heart cannot pump the same amount of blood. So since systolic pressure decreased, it may become closer to diastolic pressure, and that can lead to a decrease in the pulse pressure. Now on examination, there is a heaving apex because of the hypertrophy, hyperplasia of the left ventricle. There may also be a systolic thrill in the aortic area, because thrill is basically a palpable murmur. And cardiomegaly may also be present sometimes, again because of the hypertrophy, hyperplasia. Now the auscultatory findings are the most important, obviously, in all of these valvular diseases, and let's go to the auscultatory findings. So this is S1. This is S1, the first heart sound. The second heart sound, the two components A2 and P2, the aortic component and the pulmonary component. So S1, again, just to review, S1 occurs because of the closure of the mitral and tricuspid valve, and A2 occurs due to the closure of the aortic valve, and P2 occurs due to the closure of the pulmonary valve. So what are the findings on auscultation? So the findings on auscultation are, there may be an ejection click. And ejection click is not always heard in aortic stenosis. It's usually heard in valvular aortic stenosis. That is, as I said before, in fibrosis or calcified valve due to bivalved aorta, bivalved aortic valve. So an ejection click may occur due to the opening of the aortic valve. So this marks the opening of the aortic valve. There may be an ejection click. The major finding is an ejection systolic murmur. What does that mean? Ejection that occurs. So systolic murmur, it occurs during systole, and ejection systolic murmur means it does not occur throughout systole. It's not a pan-systolic murmur. It starts when blood starts flowing out of the left ventricle into the aorta. So why does this ejection systolic murmur occur? So S1 means basically this closure of the mitral and the tricuspid valve, and now we are pumping blood through the aortic valve. So why does murmurs occur? Murmur essentially occurs because of turbulent blood flow. So normally blood flows smoothly through these valves and in the heart, and we do not hear the flow of this blood. But murmurs occur because of turbulent blood flow through a narrowed valve or a calcified valve, or any abnormalities or deformities. So because the valve is narrowed, and because we have to pump more amount of blood through this narrowed valve, there is a visible sound that is heard, that is called as a murmur. So why does an ejection systolic murmur occur? So basically, here at the end of S1, the mitral and tricuspid valves have closed, and the left ventricle has started contracting. So initially there's a phase of isovolumetric contraction, that is, the valves are not open yet and the blood is not going out of the left ventricle. So there is no murmur at that time, because the blood is not flowing out of the left ventricle. When does the murmur starts? The murmur starts when the aortic valve has opened and the blood starts flowing through this narrowed aortic valve. That is when the murmur starts, and that is why there is an ejection systolic murmur. And as you can see from this diagram, it increases in intensity and then it decreases. Why does this occur? Because during the normal cardiac cycle, initially during the initial contraction of the left ventricle, a large amount of blood flows through it, because the left ventricle is filled with blood, and initially a large amount of blood flows through it, and so it steadily keeps on increasing. The blood, as the blood flow keeps on increasing, the murmur sound also keeps on increasing. And in the later stages of the systole, the amount of blood flow usually decreases, and so as the blood flow decreases, the murmur's intensity also decreases, and the murmur ends upon the closure of the aortic valve, because basically the murmur occurs because of flow through the aortic valve. So that is the ejection systolic murmur. And there is a soft A2, that is another finding in aortic stenosis. And why is it soft? Because A2 is basically the sound due to the closure of the aortic valve. So when the valve leaflets are far apart and when they close together, they make a louder sound basically, right? So here, since the valve leaflets are close together, the sound that they make is less. So there's a soft A2. So those are the auscultatory findings of aortic stenosis. So again, just going over them, there is a ejection click may be seen in valvular aortic stenosis. There may be ejection systolic murmur. Then there's a soft A2. So these are the usual auscultatory findings. Okay, so now a few things about the murmur. It's a harsh ejection systolic murmur that radiates to the neck. Why does it radiate to the neck? Because basically where this blood it goes upwards to the aorta and through the carotids and everything. So basically that's why it radiates upwards to the neck. And it is better heard in the aortic area or second aortic area, because that's where the aorta is situated. Okay, and it is conducted to the carotid, because as I said, the blood flow through that, and the closest blood vessels to them are the carotids. Okay, then S2 is soft, as in valvular aortic stenosis. In some cases there may be a paradoxical split, that is A2 may occur after P2, and there may also be an S4 in some cases. The other findings are slow rising carotid pulse, thrusting apex beat, and signs of pulmonary venous congestion. So again, going over the clinical features, the symptoms are, three cardinal symptoms are exertional dyspnea, angina, and exertional syncope. There may also be sudden death and episodes of acute pulmonary edema. The signs are pulse pressure is decreased, precordium heaving apex, systolic thrill, cardiomegaly. Oscillatory findings, there may be an ejection click, an ejection systolic murmur that increases and decreases in intensity, and a soft A2. In some cases there may be a paradoxical split and an S4. Okay, there may also be a thrusting apex beat and signs of pulmonary venous congestion. So now what are the complications of aortic stenosis? The complications are angina. As I've said before, why angina occurs, when syncope occurs. Ventricular arrhythmias may occur because angina. So what are the complications of aortic stenosis? As I said, angina may occur, syncope may occur, ventricular arrhythmia may occur, sudden cardiac death, infective endocarditis. Why? Because the narrowed valve or deformities, it may predispose to infective endocarditis, and turbulent flow also may predispose to infective endocarditis, and chronic heart failure because left ventricle is not able to function properly. Now the investigations. The basic investigations are the ECG, chest X-ray, and echo and Doppler. Okay, echo is the best investigation to determine aortic stenosis. ECG, it may be normal, but may show signs of left ventricular hypertrophy or left bundle branch block. In advanced stages, ECG may show a left ventricular strain pattern. So what does that mean? Downsloping ST segment and T-wave inversion. So that are the findings on ECG. In chest X-ray, it may also be normal. Sometimes it may show the enlarged left ventricle and dilated ascending aorta. And it may also show the calcified view sometimes. Echo and Doppler are our main investigations. We can assess the valve morphology on echo. We can identify left ventricular hypertrophy and assess the left ventricular function on echocardiogram. We can also see the calcified valve and the hypertrophied left ventricle. Now, using Doppler, we can measure the severity of stenosis. That's how we measure the severity. We can measure the flow across the aortic valve, and we can measure the severity of stenosis. And we can also detect associated aortic regurgitation. Other investigations are cardiac catheterization or coronary angiography. Why? If there is associated coronary artery disease, in order to rule them out, because they may predispose to angina and MI more. And sometimes these are the usual investigations that we do. And CT and MRI may be useful in assessing calcified valves and where there is uncertainty. CT and MRI may be useful in assessing calcified valves and when there is uncertainty. Okay, so the prognosis. If there is presence of angina, usually without intervention, the prognosis is 4 years. Presence of syncope is 3 years, and the presence of chronic heart failure 2 years without intervention. So in mitral stenosis, it tends to progress very slowly. It takes years and years for the patient to deteriorate. But in aortic stenosis, the pattern that we see is they remain asymptomatic for many years. So they may not have symptoms in the initial many years, but suddenly they may deteriorate and symptoms may develop. Okay, so now going on to the management. It can be classified into medical and surgical management. So basically we can categorize for the management, we can categorize patients into symptomatic and asymptomatic aortic stenosis. That is, those who have who are developing symptoms or showing symptoms, and those who don't have symptoms. So general medical treatment include rheumatic and infective endocarditis prophylaxis, and if there's any complications like arrhythmia, angina, or CHF, we should treat them with drugs. Okay, now main treatment for aortic stenosis, if they are asymptomatic patients, no matter how severe the stenosis, that is no matter how small the valve area has become, they have good prognosis, and so conservative management. So basically, as I said, we are dividing them into asymptomatic patients and symptomatic patients. So asymptomatic patients, usually we do conservative management, medical management, and it's usually for symptomatic patients that surgical indications are indicated. Okay, so if they are asymptomatic patients, irrespective of this severity, we give conservative management. But they should be kept under review. We should review them yearly or check, because if they develop any symptoms like angina, syncope, or a low cardiac output or heart failure, then it becomes an indication for surgery. If they have moderate or severe stenosis and they are asymptomatic, then what should we do? We should evaluate them every 1 to 2 years with Doppler echocardiography. So that is the medical management. So going over medical management again, first we give prophylaxis for rheumatic and infective endocarditis, drugs for arrhythmia, angina, and chronic heart failure. And for asymptomatic patients, irrespective of the amount of valve stenosis, we give them conservative management because the prognosis is good. But we should keep them under review and evaluate them with echo every 1 to 2 years for progression to the severity. Now, surgical management. So what are the indications? All symptomatic severe AS. So it's symptomatic aortic stenosis, and if it's severe, we give them surgical management. And if there's asymptomatic AS with LV dysfunction, that is the ventricle cannot properly maintain the cardiac output, that is also an indication. Ventricular tachycardia, marked left ventricular hypertrophy, and if the valve area is less than 0.6 centimeter square. So these are indications for surgery. And the procedures are aortic valve replacement. That is, we do an open heart surgery and replace the valve with a prosthetic valve. Then transcatheterized aortic valve implantation, that is replacing the valve through a catheter, or an aortic balloon valvuloplasty. That basically means we're not replacing the valve. We are inserting we are catheterizing the heart, inserting a balloon into the heart, and trying to expand trying to open or expand the valve. So aortic balloon valvuloplasty. So what does that mean? That basically means we are not replacing the valve over there. We're just trying to insert a balloon into the heart and trying to open this valve using the balloon. We are inflating the balloon and trying to open the valve and decrease the amount of stenosis. And but it has limited management in congenital. Okay, aortic balloon valvuloplasty, it may be useful in congenital stenosis, but in older patients with calcified valves, it may not be possible to dilate the valve using a balloon. So anticoagulants, they may be required in patients who have atrial fibrillation or who have mechanical valves. Thank you, and that's all about aortic stenosis.